Bismillah ar-Rahman ar-Rahim. Today I'm going to talk about how to ventilate a patient with acute respiratory failure on top of chronic respiratory failure or a patient with COPD. First, we have to understand why to ventilate. Then, what are the objectives of mechanical ventilations? Then, what are the causes of acute respiratory failure of COPD patients? And what are the targets of ventilations? What are the detrimental factors for ventilations? And then how to ventilate. How to ventilate? I think there are a lot of indications for admission of a patient to the ICU. This may be in the form of severe dyspnea that responds inadequately to initial ER therapy, confusion, lethargy, or coma, persistent or worsening hypoxemia, VO2 less than 50 millimeter mercury, or severe and worsening hypercapnia, partial pressure of carbon dioxide more than 70 millimeter mercury, or severe and worsening respiratory acidosis, pH less than 7.3, despite supplemental of oxygen and non-invasive post pressure ventilations, and hemodynamically unstable. These indications for invasive mechanical ventilations have been collected by the Global Initiatives for Chronic Obstructive Lung Disease 2013. And this in the form of the patient is not responding to non-invasive ventilations or inability to tolerate it, and respiratory cardiac arrest, respiratory pause with loss of consciousness or gasping for air, reduced consciousness or uncontrolled agitations, massive aspirations, persistent inability to remove respiratory secretions, bradycardia, hemodynamic unstable, and life-threatening hypoxemia. When you look at the COPD patient with chronic respiratory failure, this is the patient who is walking in the street. This is a stable patient with COPD. Look at the pH. The cornerstone and the diagnosis is the pH itself. pH is close to normal. This is not normal. It is not 7 before. Usually with 7.34 or 7.35. Partial pressure of carbon dioxide is high, bicarbonate is high, and this is a pH. If the patient started to develop acute exacerbations, this means that more respiratory failure, hypoventilative failure, or what we call alveolar hypoventilation, which is increase in the carbon dioxide. If it is just simple like that, this means the pH will go below this level. It goes to say like this patient that was 7.22. This increase in the partial pressure of carbon dioxide was concomitant compensation about 3 to 4 millimeter mercury for bicarbonate, milliequivalent for bicarbonate. But sometimes the patients may develop another pathology. He has got some sort of acute respiratory failure, acute exacerbations. In addition to this, the patient might have some sort of like vomiting, diarrhea, or hypotension, or impaired perfusions with lactic acidosis. And you look at the pH dropped too much to 7.07. At the same time, this carbon dioxide is high. The bicarbonate here, look at this bicarbonate close to the normal. This is a lot a big problem. This is a mixed one. So how to understand? I'm telling this in order to understand how to anticipate or to calculate the previous stable state for such patient. What are the objectives of mechanical ventilation? So why you ventilate the patients? To unload the patient. For this patient with severe spasm and weak muscles, we have to assist him. There is an increase in the afterload, and at the same time there is increase in the preload. In this case, there is increase in the afterload for these patients, and you have to unload him. Or sometimes the patient became an apnea, so you have to put him on to the ventilator. And the most important thing is oxygen supplementations. This is usually the patient with COPD. The problem of hypoxia is mainly due to increase in carbon dioxide. So it's just simple adjustment by or simple treatment for the oxygen by the oxygen mask that will be corrected. But sometimes the patient have got another problem like pneumonia or respiration or something like that. This means that the problem of hypoxia will be a little bit more difficult. pH adjustment, and this is a cornerstone. We have to return back with the pH to close to the normal 7.34 or 7.35. In this case, the respiratory problem is that one. That's why we should we should correct the carbon dioxide. We should anticipate how to wash out the accumulated carbon dioxide, which resulted into the drop of the pH. So this is a problem. So they have to look at the pH, how to restore the pH close to the normal by wash out of the carbon dioxide. This is alveolar hyperventilation, as I have mentioned before. So what are the causes of acute respiratory failure of these patients? It's very important when you go back with this formula. This is a Basher Bishop carbon, arterial Basher Bishop carbon dioxide equals the carbon dioxide output multiplied by the barometric pressure minus water Weber over the alveolar minute volume. Alveolar ventilation minute volume. This is the tidal volume minus the dead space. I mean, this is the alveolar tidal volume minus the alveolar dead space minus the alveolar dead space multiplied by the respiratory rate. So when we come to ask ourselves what are the causes of the decrease in this alveolar tidal volume, for sure, pneumothorax may be an important cause. Should consider it. Should keep it in mind. This is pneumothorax. This is a major cause, or sometimes pneumonia or aspirations. This is another important factor. The third factor, which is left ventricular failure, this is will result in decrease in this alveolar volume, and at the same time, the most important one, which is an spasm. Spasm will be associated with increase in functional capacity and the decrease in the tidal volume due to encroachment on the. This is a large functions of the capacity comes close to the total lung capacity, and so the tidal volume will be small. So these patients will suffer an important one, what we call shallow rapid respiration. We're going to discuss it later. So the tidal volume, so the causes of acute exacerbation. Look at the tidal volume, pneumothorax, pneumonia, aspiration, heart failure, and the spasm. And for sure, the dead space, alveolar dead space will be increased usually mainly by the pulmonary embolizations. And respiratory rate decrease due to decrease in the drive, weak muscles, drugs, ineffective triggering, low flow, myopathy, something like that. But usually the most important thing for this respiratory is the fatigue and at the same time the presence of intrinsic PEEP or sometimes some drugs. Look at this is very interesting table which gives you this is a picture of the patients. In other words, we sometimes you ask ourselves what is the most important problem for the acute respiratory failure. Acute respiratory failure is an alveolar hypoventilation. And just remind this alveolar hypoventilation. This is a stable patient with COPD. Look at this is respiratory is 20. The tidal volume is 400 ml. This is the tidal volume of the patients, and so the minute volume will be 8.2 liters. When you come to look at the dead space of the patient, which is a physiological dead space, which means alveolar anatomical dead space plus the alveolar dead space, about 0.5. Normally, it is about 0.3 or 0.33. So this is so there is an increase in the dead space. This increase in the space, for sure, it is not an increase in the anatomical space, it is an increase in the alveolar space. So this is the dead space. So when you come to the effective volume for a gas exchange, 50% of this tidal volume. So this is instead of being 400 ml, this is a tidal volume. It is now 200 ml. So the effective volume which rates the alveoli for gas exchange is 200 ml. That's why the alveolar ventilation volume, which is responsible for the gas exchange, this is 0.2 multiplied by 20, this is 4 liter. So this patient is COPD, he has been resetted to another level of carbon dioxide, so the partial pressure of carbon dioxide is about 46 millimeter mercury. When it comes to this patient, if this patient developed the acute respiratory failure on top of chronic, so the first compensation is tachypnea, and this tachypnea is an important one. But look at the tidal volume. Tidal volume decrease. This decrease due to the spasm, and therefore there is an increase in the functions of the capacity, so the tidal volume decrease. So this concomitant tachypnea, but at the same time there's a decrease in the tidal volume, total tidal volume. Instead of 400, now to 340 ml. So look at the total minute volume. Instead of being 8 liters, now it is 10 liters. So the patient is hyperventilating, total hyperventilation. But look at, we are going to see that this is he's specifically alveolar hyperventilations. When we come to look at the space in the normal 0.3, in the stable one it was 0.5. But this patient developed after he developed acute failure. Look at the dead space, it became 0.77. Acute, this is a 0.77 and instead of zero point 0.5. So this is increased for sure. Anatomical dead space no increase, but this is alveolar dead space has been increased. So when we look at the tidal effective alveolar tidal volume, instead of being 200, which was 50% of 400, now it is 94. It is 94 ml. That's why when you can 94 ml but multiplied by this rate 31, so the alveolar minute volume, which is responsible for the gas exchange, dropped to 50%, about 2.9 liter. That's why the patient developed a dramatic increase in the partial pressure of carbon dioxide. So from this point, you will see that the patient is suffering a alveolar dead space, increase in the alveolar dead space, and accordingly decrease in the alveolar ventilations. What will happen if you give this patient oxygen? Oxygen for sure. You will do one important point we'll see. So this is no change in the respiratory rate, no change in the tidal volume, no change in the minute volume, but there is a marked this is an increase in the dead space. Dead space, which dead space? Anatomical dead space or alveolar dead space? We should understand that when you give the patient oxygen, this action will lead to some sort of bronchodilation. So there's an increase in the anatomical dead space. That's why when you look at this anatomical dead space will be increased. Effective tidal volume for sure will drop, and alveolar ventilation will drop, and the carbon dioxide will increase. And this is what we call one of the parameters of Halden effect. So the COPD simply there is an increase in the alveolar space with the decrease in the alveolar minute volume, with concomitant increase in carbon dioxide, partial pressure of carbon dioxide, and at the same time there's an increase in the total minute volume. So this patient, when we say this patient hypoventilated, we should say this is patient is suffering of alveolar hypoventilations, not the total minute volume is increased. Taking in mind that this is the total space, is an anatomical space, alveolar space. It's mechanical is not an added. Mechanical, this will not be added to the space except if you measure the total tidal volume and use it. For this is this loss of time. This tube system will have an air or oxygen. It is not. It will not add to the dead space. The dead space is not. If you put this tube system, we're going to discuss it again in another slide, but this tube system will not add nothing to the dead space. The target of ventilations. Why? The goal of the ventilations, the aim of the ventilations. So the first thing, don't do harm to the patients. Don't do harm to the patients. And at the same time, you have to protect the patients and the lung. Provide adequate oxygenation, control the dynamic hyperinflation, adjust carbon dioxide, adjust pH, treat the cause, and early liberation of ventilations. This is my goal. So the target of ventilations from the A.B.G, that we have to come back with the pH back to normal, and the same time the partial pressure at the previous stage. So I'm going to correct that. The target point is to correct the pH, which is deviated from the normal, from the previous stage 7.3 or 7.34, and came down. So we have to correct that by restoring partial pressure of carbon dioxide to the normal, and give the least FiO2 to give partial pressure of oxygen more than 50 and saturation between 88 and 92. What are the detrimental factors for ventilations? When we start putting the patient on the ventilators, we have two important items. This is the patient with its pathology, and this is the ventilators I'm going to handle. And the target is pH, carbon dioxide, and oxygen, as I have mentioned. When we put a patient on a ventilation, we have on a ventilator, we have to look at what is the pathology of the lung. Is it zeta normal lung, COPD, bronchial asthma, RDS, pulmonary edema, and so this pathology will be reflected how to handle the ventilator, how to handle the ventilator, how to handle control value, phase variables, and type of the ventilator. This patient is a COPD respiratory problem. What are the respiratory problems should be considered while you are handling the patients with the ventilator? We have a problem with the respiratory center drive. We have a problem for respiratory muscle wasting and cachexia, and at the same time there is bronchial narrowing with intrinsic PEEP and hyperinflations and the decrease in the expiratory time of these patients. All of them, these are the problem which resulted in this outcome: high carbon dioxide, the high bicarbonate, and hypoxia. These physiological, what are the pathophysiological problems of COPD and its impact on ventilations? We usually, when we deal with the patient respiratory system, we deal with neuromuscular and the bronchopulmonary system. Respiratory center, very important. You have to look at this center. There is some sort of decrease in the respiratory center response to hypoxemia and hypercarbia. And there is an increase in the respiratory center discharge and firing, what we call this is the respiratory drive. Normally, the drive of the patient or the firing of this respiratory center is small because there is in the normal person the resistance is low, the elastance and the work is low. That's why the patient is making a smaller effort to deliver or to take its total volume. But in such patient, he is making an effort. Normal respiratory drive is about 1 centimeter water, what we call B100 millisecond. In such patient, he is making at rest his effort. His effort is firing more. He is making an effort which might be 3 times higher than the normal. He might be the drive, which is B100 millisecond, may be about 2 or 3 centimeter water, and this is close to the maximum firing. That's why this should be kept in mind for the patient. You might liberate the patient from the ventilator, and after some time the patient will fail, and you have to put him again on the ventilator. So this is what we call endurance. This decrease in the respiratory reserve capacity, as I have mentioned. Why? For this respiratory center cells show the following: there is increase in the bicarbonate, increase carbon dioxide, normal pH, increase in the ammonia, decrease in the tetraamino acids, and at the same time there is increase in the GABA or inhibitory amino acids. This increase in the inhibitory amino acids like GABA and ammonia, all these may be responsible for the decreased activity of the respiratory center and the resetting of the system to adapt to this high partial pressure of carbon dioxide. When we come to the second part, which is the respiratory muscles suffer 2 important points. The first, which is wasting and cachexia. Wasting, which is the loss of the cytoplasmic protein. This is a reversible one. And usually, the patient with COPD and in his stable state, he is losing about 20% of this cytoplasmic protein. But this wasting may go up to 70% in the patient requiring ventilations. Weight loss, this is a very important predictor of mortality. This wasting is reversible, but at the same time may be due to nutritional problem or intercellular acidosis, high carbon dioxide, high bicarbonate, hypokalemia, hypomagnesemia, hypophosphatemia, hypoxia. All these problems may be responsible for hypoxemia. The most important item for this wasting is nutritional, and you have to correct it early, and you take care and put it in mind while you are dealing with such patient. The outcome, this is a decrease in the muscle mass, and at the same time, with long-term malnutrition, an adaptive mechanism occurred in the form of changes of muscle type 2B into type 1 and type 2A, which means a decrease in the muscle strength but an increase in its endurance. The most important point, instead of wasting cachexia, this is a serious one. It is loss of the myofibrils, the contractile element, the machine of the muscle itself. And at the same time, it is usually irreversible. This is due to the activations of ubiquitin proteasomes S26 or downregulations of MyoD, which is responsible for the muscle repair via differentiation of satellite cells and maturations of myotubes. This is very important one. What are the causes of cachexia? These causes maybe acidosis or increasing the cytokines, increasing the active oxygen species, increasing catecholamine and glucagon. But the most important thing you should keep in mind use use of steroids, muscle relaxant, and aminoglycosides. That's why we should put an alarm here while you are dealing with the patient with COPD on a ventilator. Take care of these drugs, steroids, muscle relaxants, and aminoglycosides, which will push a lot of harm to the muscles of the patients, and this will be responsible for myopathy, especially cachexia, which is irreversible. The bronchopulmonary system, this is the last one, which is the major problem here is the bronchoconstrictions, which is responsible for the pathology, of the COPD patients. This leads to the dynamic hyperinflation. Dynamic hyperinflation with the presence of intrinsic V, increase in functional reservoir capacity, decrease in the inspect reserve volume, and at the same time the tidal volume should be considered. Well, this is a problem because the tidal volume here, if you give the patient tidal volume, you will be close to the total lung capacity and the patient may rupture. That's why tidal volume, when you give a tidal volume, you should keep an eye on the blood pressures. And also the presence of hyperinflation leads to flat diaphragm, and this means the function of the diaphragm is bad. The second point, which is the alveolar increase in the alveolar dead space. This is a main problem for the increase in carbon dioxide, as I've mentioned before. That these patients with COPD is having a high alveolar dead space. His patient is having a alveolar hypoventilation. These bronchoconstrictions will be associated with increase, as I've mentioned, dynamic hyperinflations, and this will lead to increase in the pulmonary vascularization due to squeeze of capillaries, and at the same time, and constrictions, hypoxic constrictions, which might lead to some sort of hemodynamics and sometimes opening of the foramen valve. Then how to ventilate. Keeping in mind the previous what we have mentioned before regarding the pathophysiology, we have to first say how to ventilate. How to ventilate, this is, we have mentioned this, we have to ventilate, this means that how to adjust control variables, the phase variables, and type ventilators in order to match these data, this pathology, and not to pay harm to the patient. First, we divide the ventilation of the patients into 4 stages. The first stage, which is start ventilation. The second stage, which is stabilization of the patient. The third, which is maintenance of the ventilation. And the fourth, which is liberations or weaning of the ventilations. Start ventilations, you have to start putting the patient on ventilator. This requires two points. The first point, we have to prepare the ventilator. The second point, we have to prepare the patient by intubation, whether awake or rapid sequence intubations. Preparation of the patient, this is done empirically. You know that the patient is bronchial asthma or COPD or ARDS. Something here, this is a patient with COPD. Take care. Tidal volume should be low tidal volume if you put it on volume control. So the tidal volume should be about 5 to 6 ml per kilogram, and the flow should be 60 if it is a patient on volume control, 60 or more liter per minute. The inspire time should be less, about less than 1 second for a patient, or you put IA ratio 1 to 4. Respiratory rate should be about 12 or 15, should not increase it, should be lower in order to give time for the in order to increase the expiratory time in order to avoid the dynamic hyperinflations and rupture of the lung. At the same time, the beep about 5 to 7 till you measure the intrinsic beep and put the extrinsic beep about 85% of the intrinsic beep. If I to any patient to start putting him of 100%. 100% FiO2, and the peak inspirator pressure, keep an eye on the peak inspirator pressure not to be about 40 to 45, not more, and the mode will be assisted controlled. For the patient should be intubated, whether awake intubations or rapid sequence intubations, pre-treatment of the patient with xylocaine or opioid or atropine or defacilitating dose of muscle relaxants and inductions with etomidate, ketamine, propofol, midazoles, and then paralyzing agents like saxanorpine. This is not the topic of our study, our lecture today. I'll skip it to the second part. Stabilization. So after you put the patient on ventilators and after 20 minutes, you have to take a sample of their blood gases. After this is the rinsing time, and after that, start to study the patients. And what is your target? Target in look at the FiO2. FiO2, I have to go down with the FiO2 to the least FiO2 to give saturations about 80, 88 to 80 to 92%. This is my target, and at the same time, when the second point, look at the pH. The pH should be close to 37, 37.35. But this is adjustment of the pH. You have to adjust the partial pressure of carbon dioxide. Carbon dioxide, in order to move the carbon dioxide, so you have to handle the minute volume in order to go with the carbon dioxide to the previous state. So how can you know the previous state? And this is a problem. So we are going to talk about it. Sedation, this is the sedation of the patients, and it's better not to give a lot of sedation to the patient. Maintenance after stabilizing the patients with these data for the normal pH close to the normal, partial pressure of carbon dioxide adjusted to the previous state, and oxygen the least FiO2. Then we have to see why did the patient develop this acute on top of chronic. If it is infection, you'll give antibiotics, pass bronchodilator, and steroid. Keep in mind, in steroid, pulmonary embolizations, heparin, heart failure, you have to treat after low body load or inotropic. Nutritionalist tests which would consider electrolyte corrections like hypomagnesemia, hypokalemia, hypocalcemia, phosphatemia, something like that. Drugs avoid aminoglycoside, steroids, and muscle relaxation, so should be considered. Keep it in mind. This is a maintenance, and after that, the weaning stage, you have to prepare the patient to liberate him. This is not the topic of today. So again, we come back to the how to adjust the ventilator. This is control variable, phase variable, and type of respirations. Control variable, this means that this is a control variable. This means what are the characters of the breath of the breath delivered to the patient. This breath, the character, it has a volume, it has a flow, deliver in certain time, will produce some pressures, and the concentration of oxygen, how much, and how much this breath repeated per minute. This is a respiratory rate. This is the most important one, apart from the phase variables. So this is a control variable I have mentioned before. This is the character of the breath delivered to the patients, and we are going to discuss it. To conclude, before we start discussing, the flow should be high in order to this will affect the inspiratory time and the respiratory rate. Take care. Increase in the flow will be associated with increase in the respiratory rate. The volume should be around 6 ml per kilogram body weight, and at the same time, with the volume, when you talk about the volume, we should consider 2 points. The volume will define the plateau pressures, and the volume with the rate will define the minute volume, which will adjust the partial pressure of carbon dioxide. The time, this is the inspiratory time, the inspiratory time should be less, should be small. The expiratory time should be large in order to allow an ambient time for the lung to exhale, because the expected time constant of this patient is usually large, or repeat both the patient on I/E ratio more than 1 to 3. The pressure, we have to keep an eye on the plateau pressure, should be about 30 to 35, and the peak inspiratory pressure should not exceed 45 centimeter water, and the FiO2 should use the least FiO2, and the required saturation of these patients is about 88 to 92%, and respiratory rate should be adjusted according to the expiratory time constant, which will tell you the maximum respiratory rate which should not be exceeded for such patient. The target is this A.B.G, as I have mentioned before. Respiratory rate, very important to know how to adjust the respiratory rate for these patients and to guard against dynamic hyperinflation. Normally, this is a inspiratory time. This is the duty cycle. This is inspiratory time, expiratory time. This is the expiratory pause. Look at this. Before we have to take care what's meant by time constant. You are talking about the expiratory time constant. This is the time required for the exhalation of about 63% of the tidal volume. So this time constant equals the compliance multiplied by the expiratory resistance. Expiratory, not the inspiratory resistance. This is will give you millisecond. Look at this. This is expiratory time constant. Will one time constant will be associated with exhalation of 63%, 2 86%, 3 95%, 4 something like that. Usually we multiply by 3. If the patient, this is a patient with normal, this is look at this patient. This patient has this is compliance is 50, and this expiratory resistance is 6. So the expiratory time constant, one time constant will be 300 milliseconds. If you multiply by 8, this is 900 milliseconds. This is nearly the time required for the exhalation of this tidal volume. Look at this patient. If the patient is having respiratory rate 10, the duty cycle will be 6. 60 over 10 will give you 6 seconds. So 1 second for inspiration and 1 second for expiration, and the rest will be for expiratory pause. If the rate increases to 20, so the duty cycle will be 3, 1 second for an inspiration, 1 second for expiration, and 1 second for as an expiratory pause. Look, if the patient, his respiratory rate increased to 30, so the duty cycle will be 2, and this 1 second for inspiration and another second for expiration and no expiratory pause. What will happen if the rate increase from 30 to 40? This means the duty cycle will be 1.5 seconds. So 1 second for inspirations, and I need 1 second for exhalations, but what is a lot for me is 0.5 seconds. So this means that the exhalation will be incomplete, and a part of it will retain in the lung to add to the function of the cellular capacity, what we call dynamic hyperinflation, and this will inflate the lung and increase the function of the capacity, and this is the pathology. Look at on the other way, if the respiratory rate is fixed at 20, and this is a normal expiratory resistance, so the time duty cycle is 3 seconds, 1 for inspiration, 1 for expiration, and 1 expiratory pause. If this resistance increased instead of 6, it became like it is double to be 12. So the time required for the exhalation, this is expiratory time constant. Expiratory time constant multiplied by 3, which is the time required for the exhalation of this tidal volume, will be 1.8 seconds. So this patient respiratory rate is 20. This is the duty cycle is 3 seconds. 1 for inspiration and 1 for expiration. No, I need, this is the time for expiration, and expiratory pause is about 2 seconds, and here I need 1.8, so I'll take 1.8 seconds for exhalations, and what's remaining is about 0.2 seconds. This is for as expiratory pause, no problem. So what will happen if the resistance increase instead of 12 became 18? So the expiratory time constant multiplied by 3, which is the time required for the exhalation of whole tidal volume, will be 2 second point 7. Here the patient respiratory rate is 20, and this is the duty cycle is 3, 1 second for inspirations, and what we are left with 2 seconds for exhalations, but I need 2.7. So this I need that, so the exhalations of the tidal volume will be incomplete, and this will lead to dynamic hyperinflation. How to solve this problem? To decrease this respiratory rate. If we decrease it, instead of 20 became 15, so the duty cycle is 4. So this is 1 second for inspiration, so we're left with 3 seconds for exhalation. So, but I need 2.7, so this is a good way by decreasing, or you can decrease the inspiratory time and shift like that. So the expiratory time constant will be calculated by measuring. This is the duty cycle in expiratory time multiplied plus the expiratory time constant multiplied by the 3. This will give you the maximum respiratory rate for such patient. Volume, very important to take care or to put in mind that the tidal volume is very important because the tidal volume multiplied by the respiratory rate will give you the minute volume, which is responsible for the ventilation itself. But we have to keep in mind that the alveolar ventilation volume, this is the most important one, and at the same time the tidal volume will determine the plateau pressure. So the tidal volume which is written here on this machine is calculated from the volume which starts from the demand valve here. From the demand valve, how much volume is delivered to these patients. So this will include the volume which is lost for the expansion in the expansion of this patient circuit. This is a tube circuit, and how much of the volume delivered to the lung to inflate the lung. This is this volume, and we call it the effective tidal volume. But this is the total tidal volume. Tidal volume. Say this is a compliance of this tube. Say is about 3, and the plateau pressure is 30. 2 by 30, this will give you 60 ml. So this means that if you are delivering 500 ml, which is calculated here, 500 ml, 60 will be lost here, and what will be delivered to the patient is 440 ml will be delivered to the lung, and this is effective tidal volume. So we have to calculate it. So this is effective tidal volume and not the total tidal volume. Total tidal volume will include this is the volume lost in the expansion of this tube according to its compliance. This should be considered in mind while we are dealing with the mathematics of the lung. So the effective tidal volume will include for sure this is the anatomical dead space, alveolar dead space, and alveolar ventilation volume. This is very important to consider. So that's why the alveolar ventilation, again, this is alveolar ventilation, this one, not all these are dead space. So this is the alveolar ventilation itself. Increasing the alveolar ventilation will be associated with decrease in the partial pressure carbon dioxide. Decrease in the alveolar ventilation will be associated with increase in the carbon from this formula. This is a very simple way. Come to this is the increase or decrease will be associated with increase or decrease on this partial pressure of carbon dioxide. Increase in the alveolar ventilation will be associated with decrease. Decrease will be associated with increase, because this one is constant at least for the same time. This is as a metabolic end product, carbon dioxide. So that's why when we deal with the tidal volume, take care. The tidal volume will be responsible for the increase or decrease of this. Increase in the tidal volume will be associated with increase in the plateau pressure. Decrease in the tidal volume will be associated with decrease in the plateau pressure, so long as the compliance is the same. So at the same time, the tidal volume multiplied by the respiratory rate will be associated for the responsible for the minute volume, which will determine the carbon dioxide. If you want to change partial pressure of carbon dioxide up or down, what is the best? To increase the rate or to increase the tidal volume? For sure, to increase the tidal volume. Why? Look at this. This is a patient is having about 8 liter. This is the minute volume is 8 liter. 8 liter from 250 ml. This is the tidal volume multiplied by 32 press per minute. 32 press per minute. And this is anatomical dead space 150. Anatomical dead space 150 by 32. This means that for this minute volume, about 4.8 liter will be lost as a dead space, and only about 3.2 liters will be delivered for ventilations. If you decrease this rate from 32 to 16, 16 by 150 ml will give you this 2.4 liter will be lost in the dead space, so decrease in loss when you decrease the rate, and the alveolar ventilation will is increased. If you decrease the rate, sure. So this means that if you want to change the ventilations, if you want to change the partial pressure of carbon dioxide, it's better to make a change in the tidal volume, not in the rate. But at the same time, keep in mind that the tidal volume, you have a limit of the plateau pressure. This is an important point. Can you calculate the question? Can you calculate the partial pressure of carbon dioxide of the stable state? Yes, We have two important methods. Number one, you can calculate it by the calculate. This is a partial through corrected, either corrected bicarbonate or bicarbonate minus 3, or the target pH. Let us see. Number one, simply, if you have a patient like that with the pH 7.2 and partial pressure of carbon dioxide 80 and this is bicarbonate, you can say this is a sample 1. Yes, maybe a sample acute on top of chronic. First, you have to deduct subtract 3 from 34 because acute exacerbation is treated that the kidney itself compensated by 3 to 4 milli equivalent per liter of bicarbonate, no more. So if we say this is a 3 compensation, so the previous state will be 31. If a previous state 31, this means that this is more than the normal bicarbonate, which is 124 by 7. We know that an increase in the partial pressure of carbon dioxide 1 will be associated with compensatory increase in the bicarbonate by 0.35. So this 7 will this 7 increase in the bicarbonate will be due to increase about 20 millimeter mercury of carbon dioxide. So the carbon dioxide in this case 20 plus 4 plus 40, this means 60. So I expect it to be 60. What about the effect of this 7 on the pH and 20 on the pH? For sure, if you calculate it, will give you 7.3, so you are right. So this change at the same time, this increase by 3 and this increase by 20 will have its a change in the pH like that, 20 a change in the pH like that. So the net effect will be this minus that will give you this, and at the same time, so simple. This is you can calculate like that, or you can correct if this is not simple. If the problem is not just simple acute exacerbation, maybe maxed, so I have to study corrected bicarbonate. Corrected bicarbonate, like this is the corrected bicarbonate equals measured bicarbonate plus an anion gap minus 12. Like this is a patient with metabolic acidosis and an anion gap of 26 millimole per liter has a serum bicarbonate 10 millimole. So the corrected bicarbonate will be, this is the bicarbonate measured bicarbonate plus 26 minus 12. So this is the corrected bicarbonate as well. This means that the patient had a normal bicarbonate. This is a simple metabolic acidosis. Look at this patient. The patient also has metabolic acidosis, an NGAB of about 26 millimole per liter, and has a serum bicarbonate 15, like the corrected bicarbonate. This is a measured bicarbonate plus the NGAB minus 12. So this is corrected bicarbonate. So this patient has a bicarbonate before this problem. Bicarbonate has metabolic acidosis with a compensatory or primary metabolic acidosis, metabolic alkalosis. This is corrected bicarbonate. So the corrected bicarbonate, you can calculate the previous state of this patient only in high NGAB, but in normal NGAB it will be difficult or impossible. Look at this example. This is a patient with a steady state stable COPD. pH is 7.34. Partial pressure of carbon dioxide 60. Bicarbonate 31. When you look at the corrected bicarbonate equals 1, this is the measured bicarbonate minus the anion gap plus the anion gap 12 minus 12, 0. So this is a corrected bicarbonate equals the bicarbonate, normal bicarbonate. This means this patient is having a stable state. Like this patient develops some sort of acute exacerbation. The partial pressure, the pH is 7.22, carbon dioxide 80, and bicarbonate 34. When you look at for these are the data of the patients, corrected bicarbonate will equals 33 plus the anion gap 9 minus 12 will give you bicarbonate 34. So this patient 31. So this is the patient that has acute exacerbations, and this is a very simple way. This is acute exacerbation. This is the previous state of the patient, or 31, and you can calculate how much was the partial pressure of carbon dioxide and the pH. This is a combined or a mixed state of the patient developed acute exacerbation at the same time developed some sort of shock or hyperperfusions and lactic acidosis. Look at the pH is 7.07. carbon dioxide is 80, and bicarbonate is 24 is normal. Look at this is corrected bicarbonate will equal this is the actual bicarbonate, the measured bicarbonate plus an anion gap. How much was the anion gap? 19 minus 12, and this gives you the corrected bicarbonate is 31. So this patient had this was a COPD, and he developed in addition to this another problem, which is some sort of acidosis, which led to the consumption of high anion gap metabolic acidosis with consumption of bicarbonate. How to adjust partial pressure of carbon dioxide in a ventilated patient? I think when we come to the same formula we have mentioned before, partial pressure of carbon dioxide equals the carbon dioxide output multiplied by the barometric pressure over the alveolar ventilations. This is a desired partial pressure of carbon dioxide multiplied by the alveolar ventilations equal the measured carbon dioxide multiplied by the alveolar ventilations. If this is a desired, this is a measured. You measure this is measured carbon dioxide. You measure it. This is known, and at the same time the respiratory rate is known, and this is you calculate from this formula. So we have this, and that this is limb is available. Desired, you put how much the partial pressure of carbon dioxide you want, and at the same time the respiratory rate is the same. So you can get the alveolar tidal volume. Alveolar tidal volume. Here, another important point, which is this is alveolar tidal volume. This is the oxygen delivery by taking the cardiac output, oxygen delivery, and the venous oxygen content. This will give you the oxygen consumption. You multiply it by respiratory quotient by 8. So this will give you the carbon dioxide output per minute. So if you have the carbon dioxide output, partial pressure of carbon dioxide, and you calculated this carbon dioxide output, so you can know this the alveolar tidal volume. The alveolar dead space percent can be measured from the capnogram. This is the partial pressure of arterial carbon dioxide minus the end tidal carbon dioxide over the carbon dioxide. This will give you the percent. And since you know this is the tidal, the alveolar tidal volume, you can know the alveolar dead space. Back again, this is the effective tidal volume equals the anatomical dead space, which is 2.2 multiplied by ideal body weight plus the partial pressure of alveolar dead space. We calculated it, and we calculated also the alveolar tidal volume, alveolar ventilation tidal volume, so we can measure this. If you want to change, this is we from the previous from this formula we measure, or we put the desired one. We have this measured, we measured it, but we from this formula we can define the desired partial pressure of carbon dioxide in order to reach to the set partial pressure of carbon dioxide. In this case, you can define which tidal volume, and at the same time you add this is the effective tidal volume, and you add the tube compensation volume. So the tidal volume will be the anatomical dead space plus alveolar dead space plus alveolar tidal volume, and in this case you can adjust it. The flow, this is an important point. This is a flow. We usually define the flow regarding the volume control, but the pressure controlled we do not. Usually, but if you are using the volume controlled, you have to increase the put the flow more than 60 liter per minute in order to shorten the inspirator time. This is the flow will shorten this inspirator time, will increase the flow, will define the inspirator time. For sure, these patients you should never ever use this inspirator pose, but our target is to decrease the inspirator time and increase the expiratory time. Flow, if you increase the flow, this reflexively will be associated with tachypnea. So from the flow also, you can measure here, this is the expiratory flow, and we have mentioned before that we should measure the expiratory time constant equals the compliance multiplied by the expiratory resistance. Expiratory resistance pressure equals resistance by the flow. This is the flow, and the pressure is the plateau pressure, so you can calculate the expiratory resistance. This is I've mentioned. Another important problem, which is the presence of intrinsic PEEP. This is the remaining part. Intrinsic PEEP at the end of expiration. So this should be normally the functional zero capacity should be present. And this means that the alveolar pressures at the end of expirations should equal the atmospheric pressure, zero and no flow. But in this case, there is a continuous flow. There is some sort of pressure within the alveoli at the end of expiration. This is called intrinsic beep. Can be you can catch it from this. This is the inspiratory tidal volume, and this is expiratory tidal volume. This is shorter than the inspiratory. Or by expiratory pressure hold, you can measure the expiratory, the intrinsic beep of the same thing. So this intrinsic beep may be due to decrease in the elastic recoil of the lung, decrease in the airway occlusion, increase in the airway resistance, decrease in the expiratory time, or active expiratory muscles. An important point in cases of patients with COPD, we have to put an expiratory, an extrinsic beep equals to about 80 to 85% of the intrinsic beep, because in order to make unloading, so this is a patient with intrinsic beep, say +7. +7, in order to start triggering or to allow the passage of air, he has to make an effort about 7 first, where this 7, this makes the pressure within the alveoli 0, the same like that. In order to allow the passage of air by a flow by a pressure difference of 1 millimeter, 1 centimeter water, so the patient has to make an effort about -8. This is large. If you put an extrinsic beep of 5, so the difference here, this is 7 in alveolar pressure, and this is 5 in the tubes. The patient has to make an effort about just 2 in order to reach the pressure here the same. This is 5, 5, and make another 1 to this will be -3 in order to allow passage of air to make a difference, and air will flow from the bronchial tree to the alveoli. So here the patient is just made about an effort about -8 in order to make a pressure gradient 1, and here he made about -3 in order to make a pressure gradient 1. So this is to be kept in mind in order to unload the patient while you are ventilating your patient. Complication of the beep is volutrauma. This is usually intrinsic beep. Decrease the driving pressures and decrease the volume. Increase the plateau pressure. Capillary squeeze. Increase pulmonary artery pressure. Increase vacuum matching. Increase the space. Increase CPB. Decrease venous return. Decrease the cardiac output. So these are the complications. Most important, patient with COPD, triggering usually is difficult due to decrease in the drive, decrease in the muscle power, in the presence of intrinsic beep. High triggering value may be a mistake, and the use of inline nebulizer may lead to ineffective triggering during flow triggering because of the interference with basal flow. The last point, which to start to use, volume versus pressure ventilations. When you look at this, is pressure control ventilations. In the pressure control ventilations, you put the inspiratory time and the pressure in addition to the resting time. This is the pressure and the inspiratory time. What will happen if the patient started to take severe tachypnea, became tachypnic, the patient was controlled, and after that he started to be assisted control, and the patient became tachypnic. Became tachypnic, what will happen? The patient will develop hypoventilation. The patient will develop hypoventilation, so take care, as I mentioned before, watch the expiratory time constant and respiratory rate. Why the patient hypoventilated? Because this is the pressure equals volume over the compliance. The rate will lead to dynamic hyperinflation. The lung becomes hyperinflated, the functional capacity will increase, and according to the volume pressure curve, this is the lung, the volume will become to the flat part. This means that the compliance here will be stationary, and here the pressure, so this is will decrease. The compliance and this part will decrease, and so the volume will decrease. So this is intrinsic B will increase. You will add some volume. Some volume. This is a pressure. You will not exceed this pressure. This is a pressure controlled. You will not exceed the pressure. So this a volume will increase. Intrinsic B, more volume. This is on the expenses of what? Of the tidal volume. Tidal volume, which tidal volume? The whole tidal volume. Including this is anatomical displace which does not change. So you are suffering, you are feeling the problem of the alveolar ventilation volume. So the alveolar ventilation volume will decrease too much. So these patients will develop hypoventilations and accordingly hypoxia. So this is the problem. When you come to the volume control, you set the volume, you set the flow, or you set an inspiratory time. This is so this is the problem. So if you have if the patient became tachypnic, what will happen? This is you have this is the pressure. This pressure will increase. The volume will be added. This is dynamic hyperinflation. So the compliance will decrease. Decrease in the compliance with the presence of this one. So this the pressure will increase. So this is the tidal volume will increase. This is the plateau pressure will increase at the plateau pressures. Here the volume is delivered whatever the change. No change in this is decrease, so this is will be associated with the increase. So this means that you are increasing the function residual capacity without limiting the pressure, so the patient will rupture. So this is volume trauma. So this is in the patient with volume controlled, you are vulnerable to develop volume trauma to the patient, except if you are not taking care with the respiratory rate, plateau pressures, and hemodynamic watch out. This machine, which is a Draeger, this is a pressure control volume target. You put it here, the Bmax. Bmax, this is a guarantee. So this is the patient. If you have this is a Bmax 35. This is volume controlled for sure. In this case, you will never put this in inspirator pose, but the volume controlled. Well, the patient you put in inspirator time, or you put high flow, so the inspirator time will be small, and the rest will be expirator time. So this in this case, if this time and the pressure is sufficient to deliver this other volume, no problem. No problem. It will be delivered in the form of volume control with rectangular waveform. But if the Bmax reaches, say you have you put it, this is 25. If the Bmax reaches, in this case, the ventilator will change from the volume control to the pressure control. This is the level of the pressure, and so the waveform, so that the flow will be decelerating. So you have a guarantee that this Bmax will not be exceeded, and so the patient will never rupture. So if you put it 25, or say 30 or 35, and the patient has some sort of problem, so this is in this case the patient will change from the volume control to the volume control to the pressure control, from the rectangular wave to decelerating wave, and no rupture of the patient. So take home message. The aim of the ventilation to wash out carbon dioxide to the previous state, restore pH close to the to 7.35, treat the cause of acute exacerbation, to liberate the patient from the ventilator early. Afraid of what? You are afraid of volume trauma and the myopathy. What to do? You have to adjust the flow, the volume, the time, the pressure, the FI2 and respiratory rate. This is my target. I think this is too much. Thank you very much.